Okay, welcome to our 20th episode of Wake Up with Walters. Today we have another guest, a very good friend of mine, OBGYN, Dr. Jennifer Brunet. She's going to join us soon, and we're going to talk with her and find out about just COVID-19 and the world of OBGYN. So let's get. So we're a few minutes late. I had a surgery this morning for breast reconstruction after cancer. Um, let's see, she's about to join.
Hey, good
Good,
morning.
good morning. How are you?
I'm good. How are you?
I'm good. Just busy morning, running a few minutes late,
That's
doctor
okay.
time.
That's okay.
How are you doing?
I'm doing good. I'm off today.
All right. You're off every Wednesday?
Just about. I usually have meetings and stuff, but yes, for the most part, this is my mental break day.
Man, how do I sign up for that?
I know, man. I tell you all the time.
Mm. Um, okay, well, let's wait a few minutes, get some people to join, and then um, we'll kind of just, what I want to talk about this morning is just, just I've had a few doctors on, and I want to talk about, really just getting back to healthcare, how, patients can, feel safe about, the things that we're doing to keep them safe. And, we've talked to, Dr. Shamia yesterday.
Mm-hmm.
I had an emergency room doctor, on at the start of all of this to talk about, really, um, the beginning of the coronavirus. And now that we're kind of almost coming out of quarantine, just want to kind of talk about that and see how you guys are
Uh-huh.
keeping your patients safe. And I've had a lot of questions from just friends of mine, who are pregnant and things like that, and people that I work with, and they have some fears about coronavirus and how they're going to continue to be able to see, their OBGYN during
Mm-hmm.
this process. So, um, okay, well, Dr. Brunet is a good friend of mine. We went to medical school together. We went to college, the same college, LSU together, really trained and around the same time. Um, and, she did her residency in, obstetrics and gynecology. And she's a busy, very well sought after OBGYN in the area. And so welcome. And,
Thank you.
I guess just tell me a little bit about yourself, and then just for the audience, and then,
Okay.
talk about, what you guys did in the initial phases of COVID-19 and how that affected your practice and your patients.
Okay, so I am happy to be here. Thank you for asking me to come on. I'm new to the Instagram thing, so look, my camera, I don't know what I'm doing, so just let me know if you can't see me. Okay.
No one's
Um,
judging. No one's judging.
okay.
This is all, everyone's home. This is quarantine time, and you know, just
I know,
all
right?
all casual.
Okay, so but yes, I'm from New Orleans. Grew up here, went to high school here, went away for medical school with you, came back home. Love being here, love the city. As far as OBGYN goes, yes, we have definitely seen the crisis with COVID-19. We're definitely fortunate enough that most of our patients are young and healthy. Um, but when this all first came about, we definitely had to make a lot of changes as far as in the hospital, the way we run our clinics. First and foremost was hospital care, just having ways to keep our patients safe. And, first and foremost was, unfortunately, to the dismay of a lot of our patients, was really limiting the visitor policy, which, breaks my hearts for the patients, because for a lot of them, they're first time moms. This is a big event in their life. And, it's unfortunate that they're not able to have all of their family members there with them. We were able to, keep the dads there, for our laboring moms.
Okay.
And which was, very important to us as providers, that, we wanted to have our patients to have that support person there. Um,
Sure.
and then we did implement about 2 weeks into the pandemic, we did implement rapid testing for COVID-19 on our labor unit. So we were actually able to rapid test our patients ahead of time. So we actually knew, those coming in, who were our asymptomatic positive patients, because for our field, as I had mentioned earlier, our patients are, generally pretty healthy. So, our biggest fear was the ones that are carrying the virus and are not showing any symptoms. And so, we were able to isolate them on the labor hall. We obviously had all of the ample PPE that we needed to deliver them effectively. And then we were able, on the postpartum side, we were actually able to set aside a hall just for our asymptomatic COVID patients. And so we were able to isolate them from the non-infected individuals. And so I'm very proud of the way they have done things, and they were able to implement things so quickly. And we were really able to keep our patients safe. And fortunately for us, we really, we did see about a 20%, I would say, asymptomatic positive rate in our patient population. But fortunately, everybody is, doing well. But it's a new way of doing things. We did have to limit the number of doctors on the unit because, as you know, we have a bunch of OBGYNs, and, it's with the constant ins and outs of the unit and different providers, coming in, we just felt like there would be too much of a risk for bringing in the virus from us, bringing it in. So we did kind of, formulate a shift work type thing where we had, one doctor on days, one doctor on nights. We did a period of, 5 days and 5 nights in a row to where we could keep continuity of care, and keep the patient safe.
How soon did you guys implement telehealth visits? And
immediately.
Yeah. And, that was something that I've been talking about for plastic surgery. We've been somewhat doing that for several years because we have some out of town patients and, but we, realized how to really do that more effectively and really, offer it to, make sure things are HIPAA compliant and, offer it to our local patients. So talk about that. Like, what patients were you seeing, like, in-person visits, and then how patients, on the obstetric side, how did you do those follow-ups?
So we actually were, lucky in the fact that before this all started, we had already had a telehealth, at least for OB, we already had a telehealth program up and going where our OB patients that initially had joined the program when they were initially pregnant, we would give them a blood pressure cuff and a scale, and they were able to actually do their vitals at home, and things would Bluetooth into their chart. So we had already implemented that a few years ago. And so we were actually really able to just kind of feed off of that and take it from, like, just kind of take off with that program. And then, we were able to do a lot of our prenatal visits virtually. So because we were able to collect their vitals at home, they were posting into their chart, and then we would do a virtual visit just like this, to see if they were having any problems or concerns. Obviously there are some things that have to be done in person, such as ultrasounds. And, once you start to get towards those end stages of pregnancies, those last few weeks, some of those visits were, important to really be done in person. But for the most part, we were ready to go with telehealth immediately. And I actually feel like you said, I just think for medicine in general, I think that telehealth is really going to take off after this. And I really think that for some of my partners, and myself included, who, I like to talk, and I'm more of a in-person kind of doctor. And I love my patients coming into the office, and we just sit around and talk. And so, for me, telehealth at first, I was a little like, oh, I'm not going to like this. But then I saw the value in it, and I saw how easily patients took to it and how well they took to it. And we were actually able to do the same thing. If anything, I probably felt it took a little bit longer because you feel like you're talking to someone on the phone.
Yeah.
But I just think moving forward, this is really going to take off in all fields of medicine, because I think patients, for some things, like to be in the comfort of their own home.
Yeah. No, I certainly think that we were, as a field of medicine, a little bit old school and behind the times.
Yes.
And now look, our best physical exam, is our hands, and doing a physical exam, not doing the imaging, not always doing, telehealth. But for patients who are out of town, especially some things that are, some post-op appointments,
Yes.
you don't have to necessarily see someone. There's a lot of things that we can judge and make sure that, and still offer, good patient care to patients. And so, and like you said, you hit that correctly, is in the comfort of your own home.
Yep.
So, because
Yeah.
people are busy, and, there's some single moms out there, and, just people who are just really busy, and they can't, get babysitters, but their health is still important. And so if we can still deliver that care,
Sorry.
see, just like you,
Yep.
no, that's okay. Where is he?
He's right there. Tell
Hello.
everybody hi. Say hi.
Hello.
Say hi, Dr. Walters. Yes, I'm
Beautiful.
babysitter today. Thank you. I'm babysitter today. So,
look, I think there's things like, right now, your babysitter, you're home on your day off, but we can still provide value in, for our audience, and help educate, again, with technology.
Oh yeah.
So
I've loved it. I've actually loved it. And I think that it will actually, moving out of this pandemic, I think that we actually will find a lot of things that we don't need to see in person, and just for
right.
for the patient themselves, like you said, we have working moms, we have moms that work shift work and, can't come in during the day. And so, I just think that as a whole, we're going to be able to just change the way we do everything, just in our appointment times that we can offer appointments, especially too, because we can do a lot of this from our house, and, they're sitting at home, or sometimes even at, work if they have to. But I just think it's going to be a great tool moving forward.
Yeah, I totally agree. So on another note, just talk about a little bit, what have you seen as far as like some moms who, are scared, about maybe their baby getting coronavirus, through the birth and things like that. I mean, what are the risks, if an infant gets it, through birth and things like that? Can you talk a little bit about that?
Yeah, sure. We have not seen that yet. Because this is such a novel virus, there's really very limited data as far as pregnancy goes. But to date, there's no, we still do believe there's no vertical transmission. So we do believe that if a mother does contract the virus while she's pregnant, we do not believe there is vertical transmission from the mother to the baby in utero. That's obviously definitely a risk, with the birthing process. If a mother is asymptomatic positive and she were, normally we do skin to skin. So if the baby were to go on her chest, it is possible that she could infect the baby that way. And so, but for those patients, we have, we're having them wear masks. We do, talk to them about isolation from the baby, which, but it's kind of a double-edged sword, because when you have a mom that's asymptomatic positive, to completely be isolated from her baby after birth, I think is very difficult, especially with breastfeeding. So we have, worked with the moms, and we definitely individualize it to, putting the baby, 6 feet away in the room. We do have like glass, the little glass shields that you're seeing now at the grocery stores and the gas stations. So we do have things like that where we can, separate the mom and the baby. But, we are still recommending breastfeeding, whether they express it by hand or with a pump, or feed from the breast. And if they do choose to feed from the breast, then we obviously tell them, to wear a mask, we have them wear masks and things like that. But realistically, to completely isolate a mom from her baby, for 1 or 2 days, she's taking the baby home a few days later. So the risk is still going to be there. So we kind of felt like, while of course, complete isolation would be ideal, until the mom tested negative, we also understand that that's just not, that's just not going to be reasonable, you know? So.
Right. Well, and I think there is some evidence that, infants and children and pediatric
Mhm.
population is not the high risk group,
Correct.
fortunately.
Fortunately,
So,
yes.
um,
Um,
yeah, go ahead.
oh, you wanted to say hi again? Okay, say hi.
Hello.
He says, I'm back.
Hello.
No, but there's also too, we do believe based upon the limited data that our pregnant population is really not at any higher risk than the general population. So
Mhm.
now you do have to take into effect, take into account comorbidities. So
Right.
if you have a mom that is pregnant that has multiple comorbidities, you would expect her to be to have the same risk of contracting the virus and having a poor outcome as a mom who is not, or a woman who is not pregnant and has the same comorbidities. And so, it's kind of contrary to what we logically think, because we normally think of pregnant women as immunocompromised, in a sense that their immune system is a little suppressed, so that it does not attack the growing baby. But we've actually found with the data that we currently have that we're really not seeing that there are any more risks. And so I've been trying to explain that to my mom, just to give them some sort of ease, that if they go outside and walk around there and they contract the virus, they're not necessarily going to be on a ventilator, or their baby's not going to die. And so we've had quite a few pregnant women that have contracted the virus and really have had very minimal symptoms.
Yeah. So moving over to the gynecology part, I mean,
Yes.
what percentage of your practice is OB, and how does it?
I would say I'm definitely, I'm not the youngest physician, so I've been out now for about 10 years, but I would say I'm probably on the younger side of my partners. And so I probably am a little bit more heavy OB, so I would probably say 65-35. And so, but I do have a fair GYN practice, but, GYN has definitely been affected. I mean, I think we've overall seen our practice volumes decrease by 50%, with patients just, a little leery to come into the hospital, not knowing what, how many COVID patients are, on the floors and things like that. But, we did, go along with, the governor's proclamation, where, we did delay all of our annual non-essential visits. So those annual exams that were just routine, patients not really having any issues, we've delayed those. We are starting to book those back in the coming months. But we are still seeing problem visits. We do not want people's health to suffer over the pandemic. And I think that is part of the issue that we're seeing in other fields, that people are really delaying care for medical problems that they have. And so we don't want that for our patients. So,
Right.
and that's where telehealth comes in. That's where telehealth really comes in, is that, for those problems, where we don't necessarily need a physical exam, or even like, contraception, things like that. We can do those things. We want people to know that we can still do those things via telehealth. And, if need be, we can, send the prescription to the pharmacy. It doesn't need to be an in-person visit.
Sure. I mean, I think for, everybody who's watching and people who will watch, that's the thing is, I think, the first 2 weeks there was a lot of unknowns. And I think,
Yes.
while things are still early and we still don't know the really final outcome,
Right.
I think we still have adopted ways that if someone really has a healthcare problem,
Mm-hmm.
we can, sure, there's risk of everything, but I feel that we can still offer safe care for patients. And it's not worth, sitting at home with fear of not going to the hospital when, you do have a problem. And, if you're noticing something GYN related, or, things like that, or even in the OB part for you, you guys are available,
Yeah. Oh,
like
absolutely.
that. Healthcare is not shut down. And, you know, like as far as GYN annual screenings, you're starting to
Yeah.
schedule those though, right?
Yeah. We're
Yeah.
starting back in. We are, right now with the stay-at-home order, we're really, trying to abide by that and really see just our, problem visits, our OB patients. But definitely starting, we are now in May, definitely probably starting at the end of May, beginning of June. We actually have a backlog of patients that we've created lists for, and we have people in our office that are actually starting to call them to say, hey, look, are you ready to come, come on back in? And the biggest thing I want to emphasize to people is that, hospitals are still very safe places, especially to give birth. One of the things that we had heard was this, uprising of women wanting to do home births because they were so concerned about, coming into the hospital and them or their partner or their baby getting COVID. And what I really want to emphasize is that the hospital is still the safest place to give birth. And, do not be afraid to come into the hospital for an emergency or even into the clinic. This is, we really want patients to take care of themselves.
Sure. Someone asked earlier, are we looking at the possibility of keeping appointment screening through FaceTime? So yes, through telehealth, right?
Yes.
Yeah.
And so, and we're not, once this is over, we're not going to get rid of telehealth. I think if anything, we've learned how valuable it can actually be, at least, especially for some minor issues, where somebody really doesn't need to come into the office to take that time, and wait in a waiting room for an hour to see their doctor for a 5-minute visit, So I think that we've definitely learned the value of that. And so we are actually going to, at least for myself, going to incorporate the telehealth visits on, for patients that are wanting telehealth, incorporate them either at the beginning of our day or at the end of our day, and on certain days of the week, because it is hard to manage patients in person and then have the telehealth visits mixed in, because if you're running behind in your in-person clinic, then that person's sitting on the line waiting for you. So we'll have to navigate that as far as, do we do telehealth visits, 2 days a week at the end of the day, or, so we're definitely gonna be working on that. But yeah, telehealth I think is not going anywhere. I think if anything, it's going to build after this pandemic. So definitely, especially for the patients that like it, don't feel like it's going anywhere, because it's not.
Well, I think, there's always been a concern about providing access to healthcare in, the rural population, in the rural areas.
Mm-hmm.
And I feel that, there are certain things where, people can at least start the conversation through telehealth, who live in these smaller communities and don't have access to coming, to see a specialist or to come to the city and things like that. And so I think that's where it can help as well, provide more access to patients that are having trouble to come see, the specialists.
The specialist, that's what I was gonna say, especially the specialists, because in our, I just know, like in our GYN oncology field, even, urogynecology, they do a lot of, they were already doing, consultations, especially for patients that live far away. It's silly, to see someone that's been referred to you and you already know what the problem is. You make them drive 2 or 3 hours. That's something that can be done by telehealth, and then you just set up surgery if that's what they need. And you have them come into town for that. So, so we were doing some of that, but for the generalists, OBGYN, telehealth has really boomed with the pandemic.
Sure.
So
So I guess from the start of everything and then now, what type of cases are you doing operative wise? I guess GYN related.
yeah, so we started back this week, and we definitely obviously started with more of we kind of tiered our surgeries as far as like, what was held off and really needs to be done now because it was held off long enough. What are those cases, just to kind of give you an example from my field, like for women that are needing hysterectomies, let's say, is this a patient that can probably wait another month? Or is this a patient who, is on the verge of needing a blood transfusion because of her bleeding, that she really needs to have her hysterectomy done? So those cases now are the ones that we've really started doing this week. But in the coming weeks, we're going to, be to our phase 3 or our tier 3 surgeries, which, are pretty much the elective. I hate to say that any surgery is really elective, in my field. I think that, we have indications for all of them, but, it's just more of your non-urgent cases are starting to be done. Now, we are COVID testing patients ahead of time. So that is something that I think will be around for a little while.
Talk about, I guess, if someone needs a time-sensitive case right now, what safety measures are you guys taking to make sure that patients are safe?
So we are co-testing all preoperative patients. Ideally, because the rapid testing it's not it's only available in certain places. We are sending our patients 24 to 48 hours ahead of surgery to have COVID testing performed. We usually would get the result back in 24 hours. As long as the patient's COVID negative, then we will proceed with the case. If they are COVID positive, then then obviously we would delay the case until if it's non-emergent, we would delay the case until the patient tested COVID negative. So it makes anesthesiologists feel better that they're not, because those are the aerosolizing procedures when they're intubating patients. And so I think it makes the anesthesiologists feel better that that we're not intubating someone with COVID who we could potentially make worse by doing surgery on them.
Yep.
And then we still, the visitor policy is still the same. As for right now, we have a no visitor policy for our, standard hospital patients. And so that is going to be a little, difficult to navigate through as we get back to regular surgeries. I mean, even yourself included, you'll start to see that as well. But, they'll have to drop the patients off at the pre-op area. The nurses will come and get them, bring them up, get them ready for surgery. They'll have their surgery, and then we call their their ride, kind of let them know when they're ready, and then they would come by and pick the patient up. So that's going to be a little different for us as surgeons, because I like I like being able for them to have a family member there. But if that's what we have to do to get back to doing surgeries, then I'm okay with that.
Yeah, and I think it's important, even for patients and family members, we're doing our best to, safety is number one.
Yep.
And so, as we navigate through this process, there are going to be some little hiccups and things like that, and things are not going to, the patient flow, may not be as streamlined as it was before, because, we're cleaning the rooms a lot longer in between cases. We're making sure that all the protective personal equipment is being utilized in the effective way. And so, things are going to be a little clumsy because it's safety first right now.
That's right.
And so, things may take a little bit longer, and, just people need to understand that, and not get upset and attitudes and mad and things like that.
Yeah.
So,
and I agree with you. As long as they know, look, we're doing it for them, and for us as well. But it's going to be a work in progress for sure, because I do think that even once things are better in the community and the stay-at-home order is lifted, I still think that hospitals are really going to still be at least as far as I understand, I don't think the visitor policy will change anytime soon. But as long as patients understand that, and I haven't really had that issue so far yet. I think most people are actually liking more stuff done than less stuff done. So I'm hoping that continues.
Someone asked, with the telehealth stuff, how do you guys get the paperwork in? Is it something that's like faxed in, or is it some electronic stuff? I guess new patient paperwork. If you have to do that, is that something that your front office deals with?
Yeah, I would say I don't really. Honestly, I don't deal with that too often. But I do know if a patient calls and says, I want to see Dr. Brunet for this problem. Even if it's a new patient, they can collect most of the information over the phone. If they have records that need to be sent, we have the option of faxing or they can email it to us. And so, but a lot of the, I think too, that the telehealth actually allots more time for the visit. So the way ours are booked is they're booked as, video visits. And so it automatically blocks about a 30-minute slot on our schedule. So it's not like your normal clinic where you're like, patients every 15 minutes, at least for myself. The telehealth gives us a little bit more time. So especially if it's a new patient, we'll have that time, to talk to them, collect the history. For those new patients, don't be afraid of telehealth. It's definitely, it's at least a way to kind of get established with someone, even if you're not having a problem. And then once things are better or you feel more comfortable, they can, start coming into the office to see us.
Same person asked about, if someone's having a symptom of the flu.
Yeah.
If somebody's having a symptom of the flu and it could be coronavirus, but they don't go get checked. And I think, I'll talk a little bit about that. Is before we have surgery or before patients even come into our office, there's screening questions that we're getting,
Yep.
and if you are having, fever, cough, other symptoms of the flu, then you're not going to come into the office right now. And that's going to be stopped. And so we're going to recommend that you do go get checked for coronavirus.
That's right.
Temperature checks.
Yes, that's what I was going to say.
Yep.
They're asking those questions before they even come into the clinic.
Right.
They have their temperature check, and then they're asking them the questions of, in the last 24 hours, have you had a cough? Have you had a fever? Have you had any upper respiratory symptoms? And then if they respond yes to that question, then they're triaged off, to a nurse to, be handled appropriately, because we don't want patients coming into the clinic with those symptoms.
Yeah. So what's, non-coronavirus related, but what's the most exciting things in the field of OB and also in the field of GYN? Are there new ultrasounds or that you can visualize the baby early? What's something that is new and exciting in the OB world, and then new and exciting as far as, maybe robotic surgery for GYN?
I would say, OB, we've had 3D, 4D ultrasound for a long time. So it is fun. It is exciting. It's for us, as a hospital system, we do it more as a, when there's a problem with the baby, but there are places that do it for funsies, you go and see your baby. But as far as that goes, that is, 4D has been around for a long time. Sorry.
That's all right.
Man, a 2-year-old.
He can be around. That's
okay. He's good. He's outside blowing bubbles. So, but yeah, and then, GYN, yes, robotic surgery, definitely. We have, there's a newer robot, I'm sure that we have just acquired that, hopefully I'll be training on soon, but, so I don't know a whole lot about it, but definitely robotic surgery is coming a long way. And that will, kind of like telehealth. I think that's going to be the wave of the future, the minimally invasive. How big of a surgery can you do for, for less equipment, so.
Do you get a lot of requests, and I'll comment on, my personal approach. Do you get a lot of requests of patients who are undergoing a hysterectomy and they want a tummy tuck maybe done? Do they ask about that sometimes?
All the time. And so, yeah. Go ahead.
Yeah, this is a surgeon, preference on whether you offer it or not. And so, my personal approach for that is I do not offer it at the same time. And the reason is because, we all want to do patient safety first. And so, any type of intra-abdominal surgery, are you there with us?
Yeah, can you see me?
Okay, yeah. So yep, it just went out a little bit, but you're fine. Any intra-abdominal surgery does have risk of, say, blood clots, and especially pelvic surgery. And so, how long does it typically take for you guys to do a hysterectomy? I guess I know they're all vary, but
it varies, for a normal size uterus, with not a whole lot of fibroids. I mean, you could laparoscopically, you could have a uterus out, and be done in about an hour. So, but for bigger cases, much larger uteruses, it could take you, 2 hours.
So 1 to 2 hours. And then, if I'm doing my tummy tuck, and, most of my tummy tucks take about 4 hours because I'm doing liposuction to the abdomen, the waist, the back. I'm incorporating some type of fat transfer. We're tightening the skin, tightening the muscle. And so once you start approaching that 6-hour mark, that's when, things for OR time starts increasing your risk. So
yes,
I just don't think it's worth the increased risk of having a blood clot, and then also of an infection. You guys are cutting through, the uterus and the cervix, and I just don't think it's worth those risks for combining elective cosmetic surgery for that. Some surgeons do it, and I guess, it's a patient by patient decision. Yeah. But I personally don't offer it. And it's not because I'm some mean plastic surgeon, and it's a good idea because patients do want to kind of take advantage of the anesthesia time, but I just don't think I think your risks go up a little bit, and that doesn't make me feel comfortable. So,
Can you
okay,
hear me?
well,
Okay. I was making sure
I
you can
think
hear me.
we've been on for yeah, we're good. Yep, we're
Okay,
good.
good. Sorry.
Well,
You know,
what's the rest of your week look like?
oh, back to
Can you
clinic.
hear me?
So my clinic, yeah, can you hear me? Can
Okay.
you hear me?
Yep, we're good. We're good.
Um,
Yep.
honestly, my clinic's been starting to ramp back up. So I feel like I'm
Mhm.
starting to get back up to, not normal numbers, but close to normal. So, so I have, in clinic Thursday, Friday, trying to utilize some of the vacation that we have now. I know it sounds crazy, but, utilize some of the vacation that we have now while there's not a lot going on. So that when, the time comes and people are back ready to get back at it. So trying to enjoy some Fridays off, I guess,
Yeah.
but there's not a whole
Okay.
lot to do. So,
Well, I I know you're busy and it's your day off, so I don't want to take you away from your
oh
son
no,
and
this
your
was
day off.
great.
So
Oh, this is good.
th
Thanks for having me. I appreciate it.
thank you for joining. I think it helped. There was just a lot of concern about, pregnant mothers and
Yeah.
safety and concerns, and I think it's provided a lot of value. And
Well,
so
good.
hopefully
I
I'll
think
see you soon,
I'm sure you'll see me very soon.
and stay safe, and
You too, Joel.
we'll talk soon. Okay.
All
Bye-bye.
right. Thank you. Y'all have a good day. Bye-bye.
Bye.